Okay, arthritis is a very common ailment. About 12 to 15% of the population, if you take over 30 years of age, have some form of arthritis. So in India, that translates to 100 to 150 million, just to show how common it is. And I'm just going to talk to you about what is the anatomy of a joint. After all, arthritis is an ailment of a moving joint. Your joints are made of materials to last a lifetime. The two ends of the bone are capped with shock-absorbing smooth cartilage that is tough, smooth, and slippery, like the end of a jewelry pearl or ice. Now, if you look at the top picture, you see the bone there, and then the end of the bone is cartilage. That cartilage is what gets eroded or worn out in arthritis. And the lower picture just shows the loss of that cartilage, which is what arthritis is all about. The knee joint, for example, is a hinge joint, just moves up and down. The hip joint and shoulder joint are ball and sockets. They move in different direction. Elbow just moves up and down. It's called a pivot joint, like a hinge joint, but slightly different. This is a picture of your hip joint. You can see that it has a ball and a socket cup. And the upper end of the thigh bone is the ball. It fits snugly into the socket in the part of the pelvis called the acetabulum or the cup. The knee joint, you have the thigh bone and the leg bone. The knee is the most commonly injured, also the commonest form joint for arthritis. And it also has the kneecap bone, which is like a little ball bearing in the front of the knee, which glides in a groove in the front of the knee. That's called the patella or the kneecap bone. And that is important for climbing stairs, getting up from a chair, and those who would like to sit on the floor. So the white glistening surface is the smooth cartilage. You can see it on your right. That's what it's so smooth before arthritis, like the surface of a jewelry pearl. And you can see that between the two bones, there's like a washer or a bushing or a shock absorber. That is called the meniscus or the cushion cartilage. That gets injured when you fall down, etc., twisting injuries. So the cartilage on both ends, they don't, in the knee, they don't come in contact because you have this meniscus bushing washer between the two. You can see the lower diagrammatic slide. And there's also a very thin film of fluid called synovial fluid that gives lubrication. So you can see on the left slide that how this is called osteoarthritis in an advanced case where the surface is worn out or rough. The smoothness is lost, and you can see rough areas. Starts by softening of the bone, then sort of flakes start, then fragmentation, or they go into fragments, and then finally complete loss, where the underlying bone is exposed without the protection of the smooth cartilage. This is called osteoarthritis, and it is also seen in rheumatoid arthritis, which osteoarthritis, excuse me. Arthritis is inflammation of the joint. There are 100 different kinds of arthritis and affects all ages. The commonest is osteoarthritis and rheumatoid arthritis. The heavier you are, the earlier osteoarthritis can occur. After all, osteoarthritis is wear and tear, or the smoothness slowly getting lost and the knee becoming rough. When the load on the knee is more by excess weight, then the wear and tear is faster. Somewhat more common in women. And I think one of the reasons for that in India is if you look at men's knees, more of the time they're straight. In women, they have a slight, in India especially, there's slight bowing. Bowing means slight bend towards the outside, and as the age grows, the bowing becomes more, so that the load is more on the inner side. It's also there in Western countries, but it's more prevalent in Indian women. And progressive pain. Not that it doesn't occur in men, it also occurs in men, but when the frequency is more in women. And the symptoms are progressive pain, pain on walking, pain on climbing stairs, stiffness, and then more active. During activity, it may increase the pain. Rest reduces the pain, and as it progresses, they may likely to have a slight limping, which progresses to become more prominent limping. There's a feeling of stiffness. Crepitations means a sound, like crackling sound. That's called crepitation or crepitus. And as it progresses, it can get, the knee can increase in the bending or the bow leg. Sometimes the bending can be in the opposite direction of what we call knock knees, where the knees come together and the feet are away from each other. That's called knock knees. The sound is a creaking or a crackling sound which patients may complain of. Now you can see this X-ray that between the two bones, there's two arrows pointing. That is where the space is lost. You see on the outer side of the knee, that is the right side of the knee, there is a space. That space is because the cartilage, the smooth cartilage and the meniscus cushion cartilage don't show on the X-ray, so they will show as a space. When it gradually disappears, these two bones will come together. And it occurs more commonly when the leg is bent. If you look closely at this knee, there's a slight bend towards the outside. That's called bow legs. So when that happens over the years, the pressure is more on the inner side, so wear and tear is faster. So instead of arthritis occurring naturally due to age in, say, 60s or 70s, this can even start in the 40s and 50s, osteoarthritis, due to what we call as deformity or a bend, called varus, V-A-R-U-S, or commonly known as bow-legged. This is more common than the other side, which is called valgus or knock knee. So if you look at the left side, this is a normal knee which has a slight bend. The middle one is bow-legged, and the right side one is called knock knees. So whenever you have bow-legged or knock knees, you can see the wear and tear is more on one side and the load is not distributed equally. So osteoarthritis occurs at an earlier age. When the patient is examined, it depends on which joints are involved. When examining, there may be some stiffness, there may be a sound that the doctor will feel when putting his hand on top of the. Sometimes there is swelling, and tenderness means when touching, there may be certain points of pain. How is it diagnosed? One is by the patient telling the history, then examining the patient, taking an X-ray to see the space between the two bones, whether it's a knee joint or hip joint, you see the space. And as I mentioned earlier, osteoarthritis, the blood tests are usually normal. And rheumatoid arthritis is and other forms of arthritis, blood tests are useful. Analysis of joint fluid means if there is a lot of fluid in the knee and we don't know the cause, sometimes we put a needle and take out the fluid and send the fluid for an examination in the laboratory. How do we treat osteoarthritis? One is modifying activity. Weight loss is very important. Patients will say, how can I lose weight if I cannot walk? Which is true. As much activity as possible. Those who have difficulty in walking, we advise them to get an exercise bicycle at home, which in front of your TV maybe, which doesn't put much load on the knee, and you exercise and you can burn calories that way. Exercises, psychological counseling, not to that greater extent maybe, just to reassure them. And medicines, finally, When everything fails, there's a surgery. Although there's no cure for osteoarthritis, proper treatment can help relieve the symptoms and prevent serious or progressive joint problems. So 2 types of treatment: surgical, medical, non-surgical, medical treatment. Again, I mentioned there is weight loss is very important. Then medicines. What are the medicines? There are different kinds of medicines for osteoarthritis. That is what is called as NSAIDs, non-steroidal anti-inflammatory medicines. COX-2 is a type of NSAID. The common ones you see over the counter, like Combiflam, ibuprofen, diclofenac. Of course, in India, you can get anything over the counter. And in the US, except for ibuprofen, the others are by prescription. Then injection treatment. This is for osteoarthritis. In osteoarthritis, we don't recommend very aggressive drugs because the joint is worn out. All you can do is help the symptoms, unlike in rheumatoid arthritis, where there is, medicines are more important. So the drawbacks of taking too many these non-steroidal anti-inflammatories, one is they can cause acidity in the stomach, and if you take a lot, you can get ulcers. If you take every day for months or years, it can affect the kidneys, and kidney function can get affected. Therefore, we don't recommend taking what we call as painkillers, non-steroidal anti-inflammatories, for long term, none every day. Then there is injections into the knee, steroids, cortisone. Not very popular these days because all it does is it masks the symptoms. When I was a student, a lot of patients used to get these steroid injections, which helps a great deal to reduce the symptoms for a short while, maybe a month or so, but gradually it makes the loss of that cartilage even more. The other side effects of steroids, if you take it continuously, tablets, is you can gain weight, your blood pressure can go up, and your blood sugar can go up. So we don't recommend steroid injections routinely. Occasionally, if a patient is having a son or daughter's wedding and wants a relief for 1 month, we sometimes do it just once, which can help them to walk during their family wedding, for example. Then surgery. What are the types of surgery for osteoarthritis? What is called arthroscopy. Arthroscopy is putting a small little telescope inside the knee without opening the knee and looking inside. But arthroscopy generally does not work very well for osteoarthritis because when the joint is worn out or it's rough, you can't make it like how it was 5 years earlier or 10 years earlier with arthroscopy. It just basically washes out the knee and gives you relief for a very short time, maybe 1 month, and that also maybe 10%, 20%. So I don't do arthroscopy routinely for osteoarthritis unless the patient also has that cushion cartilage torn or damaged. Then that can be repaired and the patient will get some amount of relief for like a year or so. Now, what is joint replacement? It's called arthroplasty or joint replacement. Now, before we go into that, primary osteoarthritis is when osteoarthritis occurs by itself. And primary osteoarthritis, the true primary osteoarthritis can affect the fingers, not rheumatoid. We're not talking about rheumatoid. It's not so common, but it can happen, and it affects the tip of your fingers, the last joint of the fingers. That, if you look at your hand, you have the knuckle and then you have 2 joints. The outermost joint is affected by this primary osteoarthritis. You get a little bony bump there, And that is, you can get that in primary osteoarthritis, whereas rheumatoid arthritis affects the second joint, that is next to the knuckle. And secondary osteoarthritis can occur, and primary osteoarthritis can occur due to your older age, due to wear and tear, 60s, 50s, 60s, 70s, and those who are overweight, it occurs in earlier age group and much more. Secondary osteoarthritis is if somebody has had, say, for example, an injury to the knee in younger age group where the joint was damaged for whatever reason. Either the ligament was damaged and the knee was sort of unstable, or the surface of the knee was damaged from like a fracture. That can lead to secondary osteoarthritis at a later age. Treatment is the same. What are the risk factors in arthritis? One is obesity, the weight-bearing joint. That means that the joints of your leg is affected by obesity, not the shoulder and elbow and the hand. Past history of an injury, yes. Occupational factors, repetitive work, those who are in a factory assembly line, keep on working. Those who use a computer a lot, I mean, it can affect the finger joints over years and years, not immediately. Does hereditary factors play a role? It does play some role. Not everybody who has arthritis, the children will get arthritis. Rheumatoid arthritis, they estimate maybe 15 to 20% of those with rheumatoid arthritis, they may be traced to a parent or an aunt or an uncle. Not 100%. As you can see here, females are more, so slightly more than males for arthritis. That is about 40% versus 28-30%. And in the older age group, you can see that in the younger the group, it's very small incidence. This is age factor related to arthritis. And over 65, the incidence is almost 60%, both sexes, male and female. And 45 to 65, the incidence of the age is 42% in that age group. It doesn't mean that all patients in that age group will get it. This means that those who have arthritis fall in this age group. 58% after 65 will have arthritis. And 42% between 45 and 65. It doesn't mean it is disabling arthritis. They may have very mild arthritis. This is osteoarthritis, which shows the bump in the fingers at the end of the joint. So treatment of arthritis, one is for pain relief and to reduce the inflammation, which is what causes the symptoms of arthritis, is the inflammation. So you reduce the inflammation. That's why we say anti-inflammatory medicines. Now, what about tablet steroids? It does reduce the inflammation, but there's a lot of side effects. Weight gain, increased BP, osteoporosis increases. Just a word of osteoporosis. People confuse osteoporosis with osteoarthritis. Osteoporosis is the bone strength, your bone density of your entire body, not the joints. And osteoarthritis is the joints. So continuous steroids actually makes you develop osteoporosis much more. Then BP, and it can cause infection by taking steroids because your immunity comes down and your blood sugar also goes up. So the side effects are so much, we don't normally give steroids tablets for arthritis, as well as into the joint. It can get worse. May give you some slight temporary improvement, but your arthritis becomes worse. Now, what is VISCO supplementation? That is the injecting a lubricant into the knee. It's a physical agent and not a drug. It's called hyaluronic acid, and what happens is that it's injected into the knee, but the body doesn't allow it to stay for very long. It may last for like 2 months, and then the body will remove it. It may give a slight improvement. In my experience, it may improve about 10 or 20% for about a month, 2 months, 3 months, and then it come back to what it was. But it's quite expensive. This injection could cost you 20,000, 30,000. So we do give it in some patients who say, want to try it out. They're not keen on surgery, and they're having quite a lot of pain. As it says at the bottom, benefit is doubtful for long term. Spondylitis of your spine is a form of arthritis of your spine where the nerve gets pinched off from the bony part adjacent to the disc. This is what it looks like in spondylitis. You can see those little projections in the front of the spine on the model in the right. And you can see the nerve coming out through a canal, and it touches the nerve. This is called spondylitis, which can affect the neck spine and the lumbar spine, common in the older age group. So treatment of spondylitis is symptoms of stiffness, pain in the neck, going to the shoulder, sometimes tingling, numbness, sometimes dizziness. It's a common problem. Most of the time it's medical treatment and physiotherapy, anti-inflammatory medicines, local heat, local balm, you know, there's those gels and ointments. Quite only in severe cases they need an operation. What is gout? Gouty arthritis. Gout is an accumulation of uric acid. It's the nucleus of the cells break down, and it deposits into the joints and the tissue. People are prone for gout where the uric acid increases, and it can cause pain starting in the toes and then can go to the knee. And you know, those in these patients with gout, the uric acid will be high. Normal uric acid is up to 7.2. So this can uric acid can be like 6.5, 7.2, about 7.58, and it requires treatment. There are medicines to reduce the uric acid and diet. Those who, not that everybody has to do this to prevent gout or uric acid. When those who have uric acid or gout, then we recommend that you cut down on the red meat. Those are non-vegetarians. Red meat is like your mutton, beef, pork, and your organ meats like liver, etc. And promote, those are non-vegetarians, promote and can have chicken and fish. And of course, your vegetarian diet is fine. You know, strangely, those in pizzas, you get those little round like shaped like a coin.
Olive.
Not, they're called, no, they are, I can't get the name. We avoid those. And, you know, they say that palak or spinach, but I don't think that that is a factor. So mostly those who have gout, we recommend more of a non-vegetarian, a vegetarian diet. And it can affect the knee joint and cause quite a lot of pain and swelling. And incidentally, alcohol aggravates gouty symptoms. That's one of the forms of arthritis. Now, infectious arthritis is when there's actually infection or pus in the joints. We sometimes see it in young children, you know, 6 months, 1 year of age, and those who are immunity is less due to, say, maybe poor nutrition. Still not very common, but we can see it. And then we can see it in adults who may be severely diabetic, who are not controlled. The diabetes are not controlled, or they are immunocompromised. For example, those who are taking chemotherapy, those who may be taking steroids can get infection directly. Other common form of infection is like a open wound in the joint, which introduce infection from outside. Or a wound over a joint. If you have a wound over a joint that gets infected, sometimes it can go inside. To diagnose it, we used to put a needle, aspirate, take out fluid, examine it, and send that fluid for examination. It will diagnose infection. Then treatment is antibiotics and wash it out. Wash out the joint with a small operation. What are the types of surgery in arthritis? I already talked about arthroscopy, which does not help that much. Osteotomy is a type of surgery for the knee. I had shown you a slide where the knee is crooked, bent. So when the knee is bent, the load is more on one side than the other side. So osteotomy makes the leg straight by cutting the bone below the knee joint and straightening the bone and putting like a small plate and stabilize that bone. And then the load is distributed. For example, in a bow leg where the bend is towards the outside, all the pressure is on the inner side. So if you make the leg straight, the load gets transferred to the outer side and gives some temporary relief. This is done in younger people, say between the age of 40, 55, and gives relief, some 50%, 60% relief for about 5 to 10 years. That is what is called as replacement, joint replacement. The unicondylar is one side, and total is a replacement of the full joint, knee and hip and shoulder. Surface replacement used to be done a lot. Now it is not done because failure rate is high. And then fusion is a type of operation where you just don't have a joint anymore, just fuse the two ends. That is done in the thumb joint, the joint of the thumb, where your thumb joins your wrist. And when there's arthritis there due to osteoarthritis, replacement doesn't work that well. It is fused, but you still have movement of the thumb, but pain goes away. Similarly, in the foot below the ankle joint, you can get severe arthritis of the small joints. So if those joints are fused, the pain, in severe cases, the pain can go away. Cartilage replacement and cartilage transplant is useful for younger patients who have had, say, a motorcycle injury or a car accident, or a football injury, and they damage the surface. And there's like a little hole in the bone or a crater in the knee joint. So there we can use cartilage transplant from the outer side of the knee, which is not a weight-bearing part, and transplant it onto that small area. But not in osteoarthritis, where the entire knee joint is worn out. You cannot replace the cartilage. It's only done for a localized area like 1 centimeter or 1.5 or 2 centimeters. Now we come to replacement. Now, before we do that, we'll come to rheumatoid arthritis. Rheumatoid arthritis affects younger people, normally, more commonly between the age of 20 to 55, and 3 times more common in women than men. It is believed to be what is called as an autoimmune disorder, where you're more or less sort of allergic to your own tissue in the joint, and you react to that, and it starts as an inflammation, and then it gradually progresses where the lining of the joint gradually, erodes the surface and then leads to the secondary osteoarthritis. And people confuse rheumatoid arthritis to rheumatism, rheumatic fever. Rheumatism is nothing but a common term for joint pains of any reason, any cause. Just a colloquial common term for pain in the joint. It doesn't mean anything. It just tells you there are symptoms of joint pain. Rheumatic fever used to be more common in the past, when there was less, say for example, it can happen in homes that are less hygienic surroundings, and it affects briefly affects the joint. Say for example, you get a lot of pain in one joint, younger people, 10 years, 20 years, and it disappears and it goes to another joint. This affects the heart. Rheumatic fever is not a permanent joint problem. It affects the heart and affects the valves of the heart. Fortunately, it's not so common now, but we still see it in the rural areas and in slums where the hygiene is less. In rheumatoid arthritis, the cause is unknown. As I told you, is believed to be autoimmune, where you're reacting to your own tissue. Sometimes after an injury, but less common. Genetically, 15 to 20% can be traced to a genetic, but not all. That means 80-85% are non-genetic. And it's symmetric, unlike osteoarthritis. It usually affects both joints, like 2 knees, 2 hips, 2 shoulders. It can affect the finger joints. That is the PIP joint is the joint next to the knuckle, not the tip. And the knuckle joints. MCP joint is the knuckle. You have in the wrist, morning stiffness. Raynaud's, wrong spelling, Raynaud's phenomena is you feel your hand extremely cold. Medication for rheumatoid arthritis is generally start with non-steroidal anti-inflammatory medicines, and then what is called as disease-modifying anti-rheumatic drugs, DMARDS. And you must have heard Donald Trump taking hydroxychloroquine for his COVID, which was, he was not supposed to take it, but he thought it's going to work. That hydroxychloroquine is useful as in rheumatoid arthritis. It is one, if you look at the third line, disease-modifying anti-rheumatic drugs, DMARDS, they actually can modify the rheumatoid arthritis. NSAIDs only reduces the symptoms. So what are these disease-modifying? One is, as I told you, is the hydroxychloroquine. The hydroxychloroquine is generally used in malaria, but it was years ago found that it works quite well with less side effects for rheumatoid arthritis. It can cause side effects causing eye problems, so one has to be constantly monitored for that. The other disease-modifying anti-rheumatic drugs are what is called as leflunomide, methotrexate, and sulfasalazine. Methotrexate is commonly used by rheumatologists. Rheumatologists are medical doctors who treat rheumatoid arthritis medically, whereas orthopedic surgeons will treat medically and surgically. Now, methotrexate is a chemotherapy drug. In high doses, it's used to treat cancer. In very small doses, it is used to control rheumatoid arthritis, and it can work quite well in small doses, 5 mg, 7.5 mg, 10 mg. It can reduce the immunity to a slight extent, but it can modify the disease instead of just improving the symptoms. COX-2 inhibitors are a type of anti-inflammatory. They can cause cardiac problems. Steroids is done in an acute situation only where the symptoms are quite severe and you want to give relief for, like, to control those symptoms quickly. Steroids may be useful, tablets. Biologic agents are not that commonly used in India. Then common non-steroidals, that is ibuprofen, naproxen, diclofenac, indomethacin, aspirin in larger doses, and the COX-2 inhibitors. There's one more than the other. It's almost a trial and error. And it can, if you keep on using them, these so-called painkillers, especially in older patients and especially in diabetics, it can affect the kidneys. So we don't recommend to use it every day for years. Once in a while, once in 2 days, 3 days, it can be used. Acidity, kidney and liver problems. They can help the symptoms. It's used over the counter and used by millions of people worldwide. One of the things that can be seen in rheumatoid arthritis is these little nodules. You can see these fingers where the knuckle joints and the second joint is affected, and the little nodules can occur called little nodes and near below the elbow. They're harmless, but can occur in rheumatoid arthritis. And osteoarthritis, we already said here, men and women are equally affected, except that women who have the bow legs, which is more common, can have osteoarthritis. That makes the number more. A joint replacement has progressed. This is the last resort. When everything fails, when the patient has tried everything, and patient is lifestyle is affected, day-to-day activities affected, walking is restricted, patient is having pain, very uncomfortable, difficulty in climbing stairs, cannot walk for even half a kilometer to 1 kilometer gives pain. Then only a joint replacement is recommended. We'll talk about a hip replacement. This is a normal hip joint. For every, it's less common than knee replacement. For every 20 patients who have knee replacement, one patient may require hip replacement. But strangely enough, in the West, hip replacement is more common. Hip arthritis is more common. And in India, knees arthritis is more common because of the incidence in Asian women where there's more bow legs or bending towards the outside in the knees. So this is a normal joint. You see the smooth cartilage of the ball and the cup of the socket. And it's excellent relief of pain. This is what a worn out hip joint looks like, where it's rough. You see those little pointed ends, which are called spurs. This is after hip replacement. The surface ball is changed and the surface of the cup, and it's like the foundation of a building. There's what I call as a stem, which takes the body weight, which goes into the thigh bone. See, there's normal space on the top. You can see there's a space between the ball and the cup. Here the space is gone. There's no space at all. It's worn out. And that's after a replacement. So what is the life of a hip replacement? Normally, if the patient is slim, it can last for 25 years or 30 years. When the patient is heavy, the number of years is less. Same thing with knee replacement. The knee replacement is actually a surface replacement, whereas a hip replacement is a real replacement. This is a section of a picture of a patient after a replacement. You can see on the left side that there's a curved, like a cap which goes on top of the thigh bone. Lower end is round. Like if you make your fist, that round end, it goes like a cap and sits. And the right side is a special plastic, which is the lining and replaces the cushion also. And it goes supported by a peg, which goes into the leg bone. This is what the implants look like. On the right side is an X-ray after a knee replacement. So in other words, a knee replacement is changing the lining of the thigh bone, the leg bone, and the kneecap bone. So look at the bottom. The knee replacement involves a surgical removal of the end of the femur, beginning of the tibia, and the undersurface of the kneecap. And they're put into place by the special glue or a cement, whereas a hip, we do it without cement. It's a normal X-ray showing the nice space between the bones. That is the, excuse me, where the cartilage is intact and gives that space. Here you can see it's worn out. There is no space on the right side of this knee because the leg is bent, bowed, and all the pressure is on the inner side. This is after replacement, which shows that the lower end of the thigh bone, upper end of the leg bone, and the kneecap bone. In a replacement, as I told you, replacement is the last resort when the patient, say, is over 55 years of age, and lifestyle is very, very much affected, and they're not able to walk for a distance, and the difficulty in climbing stairs, and their lifestyle is quite badly affected. They cannot socialize. They cannot go out much, having pain. And in the night, they get pain, Getting up from a chair gives pain. Climbing stairs is very difficult. These are the patients who need a replacement after having all kinds of treatment which has failed. But replacement should be done in an, the infection can be quite devastating. So therefore, it needs an operation theater with special air systems called laminar flow. And traffic should be very much restricted. After a replacement, patient can bend the knee the next day. There's a brace to support the knee, which is removed and exercised. And after a week, that brace is removed. Patient can start bending the knee with physiotherapy from the next day. What is called epidural catheter. During surgery, it's normally done with a what is called epidural anesthesia that's done like is done for childbirth. It's an injection in the back, and the legs are numb and the surgery is done. Most of the time it's done with that anesthesia, knee and hip replacement. And an epidural catheter is kept, a tiny little tube the size of a thread, so that the patient in his or her room will continuously get the same local anesthesia as they got in the operation theater. So post-operative pain is prevented for 48 hours. And then 48 hours later, the patient starts walking with a walker. Antibiotics are given for a few days. The patient is able to have a diet from the same evening onwards. This is what a knee replacement looks like. There is an incision. It's not done by arthroscopy. Of course, the right side is a little bigger than usual, but there is an incision. You can see the bending you can get after replacement. Patient will have physiotherapy, usually 3 to 4 weeks. A physiotherapist will come to the house and do the physiotherapy and get good bending. When you get good bending, you can also sit on the floor cross-legged after, like this, after a few months. Shoulder replacement is less common, but sometimes it can happen. And usually the ball only is changed, gets great relief. We use computer navigation just to get more precision. But nowadays that's used less often. This is a patient who has rheumatoid arthritis. You can see patients, painting these things and selling them. You can see the fingers. This is a patient who actually came to the US from Bangalore when I was there in '91. A hip joint is still going strong. Rheumatoid arthritis. So many patients with rheumatoid arthritis who cannot use the hand will use these kind of aids or assistance type of devices to eat well, like this spoon and fork you can see. They can lead after replacement, can lead a full and active life. So conclusion, we discussed about medical treatment and joint replacement of the knee, hip and shoulder. Partial knee replacement nowadays in India is not used that much because the number of years is less. Whereas knee and hip replacement in a slim person can last 25 years or more. And say, for example, if the patient is in the 60s, most of the time you don't have to do a second one. If the patient is young in the 40s or 50s, there's a chance of needing a second one in the late 70s or 80s, only if necessary. Patient is completely relieved and lifestyle which is restricted. Patients can walk after, say, a knee replacement. They can say only one knee is affected. They can walk 3 kilometers after that. They can stand for an hour and a half. They can do cooking, housework. Climbing stairs to 2 floors is easy. Patient can, be pain-free and lead quite an active life. If both knees are affected quite a lot, we often, after 60, we do one knee at a time. And if we are going to do both knees, we do it with a gap of 5 days in the same hospital. In the 5 days, patient can start walking on the second day. By the 3rd and 4th day, the patient is walking with a walker, putting full weight on the ground and walking in the corridor of the hospital. Then the second knee is done. Only those patients who have both knees involved. Otherwise, one knee, they can go home on the 4th day. They're able to go to the bathroom on the same day of discharge using a walker. Walker is about 2 to 3 weeks and a walking stick 2 to 3 weeks with physiotherapy for the movement. The American designs are the best, that's what we use, and they have high flexion, lowest line you can see, or good amount of bending.
So then I have about 3 questions which are pretty much on similar lines. Geeta wanted to know, should exercising on cobbled surfaces be avoided, as whenever she does it, she can experience some pain.
Cobbled surfaces.
Cobbled
Yes.
surfaces.
Yes. Any rough surface can aggravate symptoms, so they should be avoided. Smooth walking surface is preferable. You know, like your sidewalk, footpath, your tiles, preferable. But you know, depends on the severity of the arthritis. In mild cases, walking up in a park is fine on a normal earth surface. But cobble surface, of course, is irregular and should be avoided.
Oh, that's good to know. And there were other questions which were similar. Somebody had asked, is cycling avoidable?
No, cycling is actually good in the sense that there's not much load on the knee because you're not putting your body weight. And the resistance, the cycle, you know, you can adjust the resistance of your pedaling. You reduce the resistance, that's all. But cycling is okay for exercises and building up the quadriceps muscle. The quadriceps muscle is the big muscle in the front of the thigh. That is very useful. So it's quite okay. It's also good to those who are obese, who have difficulty in walking distances. They can actually use an exercise bike and reduce weight.
Okay. And how about then, you know, the inclined treadmill? Is that avoidable if one has knee issues?
Repeat the question.
Inclined treadmill. So you can incline on a treadmill, right? You can do an inclined walk.
No, it should be a flat treadmill.
Yeah.
Better.
And how about climbing stairs?
Climbing stairs, if it is painful, if it is to reduce it as much as possible, to where if it is necessary, only climb stairs. Somebody, you know, is living on the first floor, you cannot avoid it, but number of times you go up and down can be reduced.
Okay. All right. Now, somebody had asked, with moderate osteoarthritis, how long can a patient walk on a daily basis?
It depends on how much it bothers you. Ultimately, any treatment is based on how much it bothers you. We don't treat a patient, just say a patient has an X-ray which shows osteoarthritis, but hardly any pain at all. It's based on symptoms. So how much can they walk is based on pain. The more the pain, the less, but you can walk as much as you want to and as much as you are able to. It is a study that if you lose 10% of your body weight, you can reduce 25% of your pain. So one way is walking, but instead of walking 2-3 hours, you can get an exercise bike and use it also. So your distance of walking will be less and the load is less, but still aerobic exercise is there.
I had both my knees replaced 15 years back. One of my knees has started to give me trouble now and have been suggested to do revision surgery. So how is the revision surgery done and what is the recovery after that?
Revision surgery is usually done if the implant gets loose. Now it's firmly embedded and it usually has a long life. But if it's 15 years, maybe it started to get loose, X-ray will show it. One thing that has to be looked for, excuse me, is that there is no infection, which can be detected by doing a blood test by what is called as ESR and CRP. Again, revision is not done with an X-ray showing it is loose. Again, if the patient is disabled, that means patient is having quite a lot of symptoms. There's a lot of pain, not able to walk for a distance, climbing stairs is painful. In other words, if the lifestyle is quite badly affected, then may require it or try to put it off as long as possible. Unless it's giving a lot of trouble and it bothers you a lot, then it should be done.
Oh, okay. Now, a couple of questions came around how to delay the onset of arthritis. Are there any food supplements? Is there anything that can be done about it?
The most important is to keep your weight down. Those who are slim, have you seen people who are 90s sometimes who don't have arthritis because they are slim, very slim. And of course, they may not have deformities. That's why you'll see men sometimes, no, but their legs are straight. But then men, the life expectancy of men is less than women. But you'll see, you know, there are women you'll see in the 80s and 90s who are walking around okay, because they are basically have been slim their lives, and men. So that is the most important factor.
Okay. So Mr. Bulchand has asked why performance after knee replacement varies with people of same age group.
There are different factors. One is the type of implant used, the how severe it was before, and if there were no complications, right? Then it is basically the type of implant that is used. The superior the implant, the better the results. Then they should, you know, make sure that there was no infection. So they have to prevent infection by hospitals that have the specializing in replacement, with having exclusive operation theaters only for replacement. Very few hospitals have that. I mean, I don't want to brag, but HOSMAT, being an orthopedic hospital only, has 2 theaters only for this. And there are 1 or 2 hospitals in each city will have that. That is separate operation theaters. But what happens is you have to look at the practicality. When you have a general hospital with 25 departments, it's very difficult to give one theater only for a knee replacement. So anyway, that infection is a common cause of complications. Then the other thing is that how well it was corrected. And if the more the pain before surgery, the happier the patient. In other words, if you do a replacement on somebody who had only mild symptoms and didn't really need it, they're not as happy or pleased as a patient who had very severe disability and pain, and then you cure it completely, they are very happy. If you have only a mild pain, they're not that happy as somebody else who's had a severe arthritis. So that is another factor. And weight, the heavier you are, you don't get as 100% relief, but you still get, 90-95% relief. So when they lose weight, they get better and better. So what generally I do is, if sometimes we'll do it in a lady who's 90 kilos, okay, sometimes even 100 kilos, or men who are 100 kilos, 110 kilos. We usually tell them, well, they say, I've tried everything, I cannot lose weight unless I walk, which is true. Therefore, advise them, counsel them that the surgery will be done only if you're going to walk, and assure you're going to walk 2.5 kilometers every day after 3 months. Otherwise, don't do the surgery. Because there are patients who say, yes, I'll walk, and they don't walk, and they're still heavy weight, and then a number of years it comes down. But it works very great in those patients who want to walk and are heavy, and you do the replacement, cure the pain, and they can walk 3-4 kilometers every day and lose weight. But after 3 months, 4 months, not immediately.
Walking in the pool help for knees?
Swimming, you mean?
Yeah, swimming pool. So they're talking about walking in the swimming pool, not swimming, walking in the...
Because water has what we call as buoyancy. When you walk in a pool, your load on your leg is much less. You reduce your load by 60-70%. So it's good. You're not putting as much weight, and you can do more walking in a pool than you can walk on the normal ground. Yes, definitely. It's a good idea.
Okay, great. So thank you so much, doctor, for being here with all of us and spending your time and educating us on what arthritis is all about and what should one do.